Well, good evening. I want to welcome everybody to this week's rendition of Happy Hour. As always, I'll be minding the chat, but if you have any questions, you can email them to RSVP, not RSVP, education@sagesdx.com, excuse me, or you can email me directly, tdavis@sagesdx.com, and I never mind getting phone calls or text. My cell phone is 210-416-4815. So we're going to be kind of rounding out our series on Dermpath essentials this week with an actual practice session. We have 9 unknown slides, and I tried to pick slides of varying degrees of difficulty, so those of you who are upper levels could work through them as well. So without any further hesitation, we will go ahead and get started. And I'm going to start each case by giving you the diagnosis and then working through how I tend to approach the slides. So slide number 1 was a case of chronic urticaria. And this is a bisected punch biopsy. This is from the trunk. And as we detailed during our last session, trunk skin tends to be characterized by a thick dermis, and a fairly low concentration of follicular and sebaceous elements. Now, hopefully it was pretty obvious that this was an inflammatory condition. And as we move into higher power, I think I'm going to focus on this piece on the left, you can see that there's a very sparse, superficial and deep perivascular infiltrate. And there are no epidermal changes in this particular biopsy specimen. I'm going to tilt it a little bit. You can see that we've got a basket weave cornified layer and an epidermis of normal thickness. Now, as we move into higher power, we can see that the infiltrate, like I said, is sparse. It's centered around vessels of the superficial and deep plexus, but there's a little bit of an interstitial component. You can see the inflammatory cells starting to intercalate between the collagen bundles in the dermis. And if we go down and take a look at the inflammatory infiltrate, we can see that it's mixed. And indeed, if you got a perivascular dermatitis without epidermal changes and there's an interstitial component, 9 out of 10 times the infiltrate is going to be mixed, and your differential is going to be predicated on identification of the inflammatory cells comprising the infiltrate. Well, here, we can see that we've got a number of lymphocytes present, but in addition to lymphocytes, we've got eosinophils. You see one here, and also scattered throughout the infiltrate, we have a few neutrophils. Here's a neutrophil over here. I'll go ahead and circle it with my pencil here. And the eosinophils and neutrophils are present in about equal numbers. So the presence of a perivascular and interstitial infiltrate, superficial and deep, with eosinophils and neutrophils should make you consider the diagnosis of chronic urticaria. One can get similar changes in urticarial drug eruptions. Now, a couple of points about urticaria. As a chronic urticaria, as you're aware, is frequently biopsied to rule out urticarial vasculitis. But you can see in this particular specimen, there's no evidence of small vessel vasculitis. There's no fibrin in the vessel walls or lumina of these postcapillary venules. There are really no extravasated erythrocytes and not much in the way of neutrophilic nuclear dust. Acute urticaria doesn't get biopsied very often. In acute urticaria, one usually sees just the sparsest of perivascular lymphocytic infiltrates. And frequently what one will see in acute urticaria is neutrophils within vessel walls. You can see a little bit of that here. And sometimes there's a tendency of the neutrophils to line up along the periphery of the postcapillary venules, margination, so to speak. And then ultimately, as the urticaria becomes more chronic, the neutrophils and eosinophils work their way out into the dermis. And despite the presence of edema, clinically in lesions of urticaria. The edema associated with the urticaria is not visible at all in H&D stained sections. So if you're thinking about urticaria, don't let the absence of appreciable edema in the dermis keep you from making that diagnosis, because you're just not going to see it. It's more of a clinical change. Okay, we'll go ahead and move on to slide number 2. Let me tilt the slide here. And here we have a somewhat timid punch biopsy specimen. It's kind of difficult to ascertain location here. We do have a fairly sizable follicular and sebaceous unit here. So this could be from the trunk, or could even be up from near the head or neck. We know we're not obviously from volar skin. And here we have a neoplasm. And it's hard to assess all the architectural features of this neoplasm because it's been partially sampled. But we can see it's fairly sharply circumscribed. It's not encapsulated, but you can see the outlines of the neoplasm pretty well. And this is a mesenchymal neoplasm. And it is composed of fascicles, intersecting fascicles of spindle-shaped cells. Some of the fascicles, and I'm going to get my pencil here, are cut in cross-section, and some are cut longitudinally. Obviously, we're looking at a two-dimensional representation of a three-dimensional structure. And when we take these spindle cells and cut them in cross-section, the nuclei look round rather than a spindle-shaped. If we do look at the fascicles of cells that are cut in cross-section, you can see that the nuclei, the spindle-shaped nuclei comprising this proliferation, are fairly large, and they have blunted nuclei. They're somewhat cigar-shaped. And you can see there are perinuclear vacuoles present around the nuclei comprising this proliferation. The cells are fairly uniform. There's not a lot of nuclear pleomorphism or hyperchromatism, and mitotic figures are not readily identified. And this histologic appearance is very characteristic of a leiomyoma. And that's what this particular tumor is. This is a cutaneous leiomyoma. As you're probably aware, leiomyomas can be solitary or multiple. When they are multiple, then one has to be concerned about the possibility of Reed syndrome, which is an autosomal dominant condition characterized by fumarate hydratase deficiency. And patients with Reed syndrome get multiple cutaneous pilolyomas. The female patients with Reed's also tend to have a lot of uterine leiomyomas that are higher risk for uterine leiomyosarcoma. And the patients are at risk as well too for papillary renal cell carcinomas. Now, we could confirm the diagnosis of a smooth muscle tumor here with the use of immunohistochemical stains. This tumor would be strongly decorated with antibodies directed against smooth muscle actin and desmin. So we've looked at an inflammatory condition and a neoplastic condition here. Slide number 3, and I realized I didn't give you the diagnosis at the get-go on slide 2. I'll try and remember to do it moving forward. Slide number 3 was a large shave biopsy, and the diagnosis in this case was coccidiomycosis. And as we move into higher power, we can see that we've got fairly pronounced epidermal hyperplasia, and we've got almost a nodular inflammatory infiltrate throughout a very sclerotic and fibrotic dermis. You can see that the collagen bundles are thickened and somewhat hyalinized without really an appreciable increase in the number of fibroblasts. If we move to higher power, we can see that we've got a mixed inflammatory infiltrate here. There are a lot of lymphocytes present within the dermis. And in addition, we've got these nodular collections of epithelioid histiocytes forming granulomas. And these really are almost tuberculoid granulomas, and that we've got epithelioid histiocytes surrounded by a cup of mononuclear cells. And there were a fair number of multinucleated histiocytes as well. Now I'm going to back out and go over to the left side of this particular biopsy specimen. And I'll kind of zoom in slowly so we don't get any pixelation. And again, you can see we've got these multinucleated epithelioid histiocytes. But as you looked around here, within the cytoplasm of some of these epithelioid histiocytes, hopefully you were able to pick out the spherules of coccidiomycosis. And you can see these spherules are surrounded by a somewhat homogeneous refractile wall. And the organisms themselves have kind of this lacy blue-gray cytoplasm. I think that there were a couple of organisms here where I could see some endospores. Let's look around and find a couple more of the organisms here. You have to kind of look around, but a lot of these were in multinucleated histiocytes, which is a good place to look for the organisms. And I'm just going to hunt around here a little bit more. And again, here are a couple more of these spherules here. Now, Cocci is caused by an extremely large fungus. It's about one of the largest fungal organisms that we see in dermatopathology. The spherules tend to be in the size range of about 10 to 80 microns. And in most tissue sections, you've got a ready-made ruler in that if you can identify a lymphocyte or an erythrocyte, these cells have nuclei that are about 5 microns in diameter. And it's good to commit that size to memory, because then when you find an organism, you can compare it to the size of the lymphocyte, and you can see these spherules are in the 20 to 40 micron range, so they're extremely big. About the only organism that's bigger than this that one can occasionally see in skin biopsies is rhinosporidiosis, and that tends to occur on mucosal surfaces and is much more not encountered as frequently. Here's another spherule. We've lost the cytoplasm, but you can see the refractile wall. So this was an example of coccidiomycosis, which tends to induce a granulomatous response in the skin. Okay, going ahead and moving on to slide number 4. Slide number 4, and I'll tilt the slide here, was a depositional disorder. This was a bisected punch biopsy specimen. And the specimen was from the distal lower extremity. The dermis is relatively thin. You can see we're starting to pick up a little fat at the base of the biopsy specimen. And if you look at the vessels in the papillary dermis here, you can see that they're a little thick-walled. And thick-walled vessels, of course, are common on the lower extremity. They tend to get thicker the older we get with hydrostatic pressure. And the correct diagnosis in this case was lichen amyloid. And indeed, if you look in the papillary dermis here, you can see that a few of the papillae are widened. And within the widened papillae, there are these amorphous pink and somewhat fissured deposits of keratin-derived amyloid. Typically in amyloid, you're going to see scattered melanophages and a variably dense infiltrate. Here we've got some lymphocytes and some eosinophils within the infiltrate. The deposits in lichen amyloid are not necessarily bigger than those that we see in macular amyloid. What distinguishes the two is the presence of lichen simplex chronicus in lichen amyloidosis. So a good way to think of lichen amyloidosis is macular amyloid with overlying lichen simplex chronicus. It does tend to localize lichen amyloid to the lower extremities, commonly found on the anterior tibial surfaces, whereas macular amyloid we tend to encounter more commonly on the back. But you can see that there is evidence of lichen simplex chronicus here. We've got hyperkeratosis, hypergranulosis, epidermal hyperplasia, and then this keratin-derived amyloid. And the amyloid, of course, can be stained. You really don't need to stain it. It's got a very distinctive appearance on H&D stained sections. But if you wanted to prove that it was amyloid, we could stain it with a Congo red stain or a crystal violet stain. And we can even use IHC stains, immunohistochemical stains directed against keratin, and that will also stain the amyloid deposits. So lichen amyloidosis, an example of a depositional disorder. Okay, moving on to slide 5, we're going to head back into the neoplastic realm here. We've got a bisected shave biopsy specimen. And it's kind of hard to ascertain location here because the tumor takes up most of the dermis. We can see in this particular instance that rather than dealing with a mesenchymal tumor, we're dealing with an epithelial tumor. This particular neoplasm is attached, does show attachment to the overlying epidermis, and then emanating from the undersurface of the epidermis and extending down into the dermis, we've got these smooth lobules of epithelial cells. If we move into higher power and take a look at the epithelial cells, we can see that they've got uniform round to oval nuclei, and most of them have fairly abundant clear staining cytoplasm, and that these clear staining cells are filled with glycogen. So we've got glycogenated epithelial cells here. If we look out at the periphery of the lobules, the junction between the lobules and the dermis, we can see that the cells out at the periphery have more of a cuboidal to columnar appearance. They definitely are palisaded, and many of these are situated on a thin basal lamina, which is easier to see in some areas than others, but that the epithelial cells are sitting on this lamina, basal lamina. And this is an adnexal neoplasm with follicular differentiation. This is a trichilemmoma, again, an adnexal or follicular tumor with outer root sheath differentiation. And trichillemmomas tend to occur or locate clinically to the central portion of the face, commonly around the nose or the lip. And they can be a marker when multiple for patients with Cowden syndrome or the multiple hamartoma syndrome. Okay, I just realized I didn't give you the answer at the get-go again. Okay, let's go ahead and move on to slide number 6. Slide number 6 is another neoplasm. This is a bread-loaved kind of scoop shave, and this is from really sun-damaged skin of the face. Note the presence of pronounced solar elastosis and large sebaceous glands. And the correct diagnosis in this case was angiosarcoma. And one can see, even at low power, that this is a vasoformative tumor. This is making vascular spaces. If you look within these spaces, you can see RBCs, and the channels do have an endothelial lining. But these are extremely jagged, crack-like vessels. And rather than being lined by flattened endothelial cells, these are lined by very atypical, plump, almost epithelioid endothelial cells. Mitotic figure here, mitotic figure here. The nuclei are very hyperchromatic. They're beginning to jumble up and fill the luminum. And again, we've got these very crack-like or jagged vascular spaces dissecting between collagen bundles on severely sun-damaged skin of the head or neck, which is, of course, a classic location for angiosarcoma. These neovascular channels, these neoplastic vascular channels, have actually been likened on scan, a metaphor that's used sometimes as lightning strikes. And I do think they have irregular shapes. They do kind of resemble lightning strikes. Much more cytologic and endothelial atypia in angiosarcoma than, say, in Kaposi's sarcoma. And think about it, angiosarcoma has pretty characteristic clinical settings in which it tends to occur. Severely sun-damaged skin of the head and neck of middle-aged or elderly individuals. Dislocation is really common for angiosarcs. We tend to see it, of course, in the setting of chronic lymphedema, and we can see it after radiation as well, too, especially on the breast or in other sites that have been radiated. So this is an angiosarc. One could confirm the vascular nature of this tumor with endothelial markers, and good vascular markers for that we tend to use for endothelial lineage are CD34, CD31, and ERG. ERG is a nuclear marker, and it's particularly clean, a very, very good marker. So angiosarcoma here. Go ahead and move on to slide number 7. Slide number 7, we're entering back into the inflammatory realm. I'm going to tilt the slide here. And again, we've got an inflammatory dermatosis. We've got a bisected shade biopsy specimen. And this was an example of pityriasis lichenoides at varioliformis acuta, kind of the real acute form of Mucha-Habermann disease. This was a shade biopsy from the trunk, and one can see that we've got a superficial and deep perivascular infiltrate here, not too much of an interstitial component here. And then, as is the case with most inflammatory conditions, the first thing we want to do is ask ourselves, are there any epidermal changes present? And as we move to higher power, we can see that the interface is not real crisp here. We've got vacuolar change along the DEJ, and we've got this patchy band-like infiltrate of lymphocytes obscuring the dermal-epidermal junction. So clearly we have an interface dermatitis. If we look at other changes that are present within the cornified layer, we do have a little bit of basket weave orthokeratosis, but the cornified layer is punctated by mounds of perikeratosis containing a few neutrophils. There are scattered necrotic keratinocytes present within the epidermis. There's vacuolar change along the DEJ. And within the underlying dermis, there's a perivascular infiltrate around vessels of the superficial and deep plexus that is composed almost entirely of lymphocytes. Few histiocytes, lymphocytes. Now, there are a lot of extravasated erythrocytes in the papillary dermis, and there's even some extension of these extravasated erythrocytes up into widened intercellular spaces in the epidermis. And while this is not a specific finding unique to Mucha-Habermann disease, we frequently do see it in the setting of Mucha-Habermann disease. You can see it in PR and other inflammatory conditions, which are characterized, however, by kind of an explosive onset. But this constellation of findings is extremely characteristic of PLEVA or Mucha-Habermann disease. Now, there are two other conditions that always enter into the differential with Mucha-Habermann disease, because they can show similar changes in the epidermis, in that they show vacuolar change along the DEJ, variably dense infiltrate in the dermis, and necrotic keratinocytes. And those two conditions are erythema multiforme and fixed drug eruption. With erythema multiforme, you do get a perivascular infiltrate of lymphocytes like we do in Mucha-Habermann disease, but the inflammatory infiltrate is combined to vessels of the superficial plexus, and the cornified layer is different. In EM, we get a basket weave cornified layer. We do not see mounds of perikeratosis containing neutrophils. And those two things are what discriminate or distinguish erythema multiforme from Mucha-Habermann disease or PLEVA. Fixed drug eruption can show identical changes in the epidermis. One can see perikeratosis in a fixed drug eruption. And again, vacuolar change, necrotic keratinocytes. But in a fixed drug eruption, the infiltrate in the dermis contains lymphocytes and eosinophils. And if you don't have eosinophils, it's pretty doggone hard to make the diagnosis of a fixed drug eruption. So the presence of eosinophils militates against the diagnosis of either EM or Mucha-Habermann disease. Okay, let's go ahead and move on to slide number 8. Okay. Slide number 8 was a broad shade biopsy specimen. And this was from sun-damaged skin of the arm, fairly low concentration of follicular and sebaceous elements. You can see some fat down at the base of the specimen. And again, severe ciliary elastosis. And the correct diagnosis in this case was melanoma. Now, when we assess melanocytic tumors, you always want to start at low power and you want to look at size, symmetry, and circumscription. And sometimes in scanned images, it's a little bit hard to get scale. I will tell you that this this lesion was shot at low power. This was roughly a 7 to 8 millimeter lesion. The lesion was fairly broad. It was poorly circumscribed, so we like to assess size. Circumscription, you can see that this lesion, there are solitary units of melanocytes that tend to trail out to the periphery. So it's not real sharply circumscribed, and it's somewhat asymmetric. We have a bunch of big nests over in this half of the specimen, but a lot of solitary units over here. So when we look for symmetry, we not only look for symmetry in how the neoplastic cells are arranged within the epidermis, we can also look at symmetry of the pigment deposition within the tumor and symmetry of the inflammatory infiltrate. And so we have a little bit more, a little bit of asymmetry in the inflammatory infiltrate here as well. If we move to higher power and start looking at this tumor, you can see that this lesion is characterized by an epidermis with effacement of the reedy ridge pattern in areas. And you can see that there are confluent solitary units of melanocytes, some extending into the overlying epidermis, some pagetoid scatter. And then we've also got nest of melanocytes, but notice that the nest of melanocytes are variable in size and shape, and they're not equidistant from one another. So right away, even before we go down and take a look at the cytologic features of this tumor, we can see that it's extremely architecturally disordered. Not only that, there's a component of the dermis here. It's on really sun-damaged skin, so we want to be careful just because of the location and have a high index of suspicion for melanoma. If we take a look at these melanocytes, we can see that the nuclei are pleomorphic, some are hyperchromatic, and there's quite a bit of pagetoid spread or buckshot scatter. You can see solitary melanocytes present within the mid-spinous layer, even up in the granular, and in some areas we even have a few melanocytes up in the cornified layer. Also, if you take a look at the cytoplasm of some of these melanocytes, you can see that these cells have abundant pale gray cytoplasm. And whenever I see this pale gray cytoplasm, it kind of reminds me of a smoking lounge in the airport. You know, you sometimes walk by them and a lot of people smoking there, and the air in those small rooms kind of resembles this color here. And anytime I see melanocytes on sun-damaged skin with this pale gray cytoplasm that looks like a smoking lounge, I put the brakes on. That's commonly seen in melanoma. Many of the cells also have prominent nucleoli. So in short here, we have a melanoma here. This melanoma had a depth of about 0.4 to 0.5 millimeters, superficial spreading type of malignant melanoma. Okay, we'll go ahead and close out with case number 9. And this was a very fragmented biopsy specimen. And the correct diagnosis in this case was an infantile digital fibroma, also known as aggressive digital fibromatosis. And one can see that we've got an epidermis which is mildly hyperplastic. Actually, we have some hyperplasia here of very elongated acrosyringeal elements, eccrine ductal elements. This was from acral skin. Notice that the cornified layer is a little thickened. The epidermis is thin. And then in the dermis, we've got another mesenchymal proliferation here. We've got a proliferation of spindle cells. And the spindle cells are arranged in kind of haphazard fascicles, much like we saw with the Leiomyoma. You can see, however, that these spindle cells are more delicate than those of the Leiomyoma. They aren't quite as plump. They're fairly uniform with an evenly dispersed chromatin pattern, not a lot of nuclear hyperchromatism or pleomorphism. And again, some of these are cut in cross-section. The nuclei are a little more rounded, and some are cut longitudinally. Now, the key to getting the correct diagnosis here rested in recognition of these round pink eosinophilic inclusions, which many of which were perinuclear in the spindle cells. And you can see one here. And once you start seeing one, you can see that most of the cells have these homogeneous eosinophilic deposits or inclusions rather within the cytoplasm, many of them perinuclear. And these are pathognomonic for infantile digital fibroma. These will stain positively with PTAH, phosphotungstic acid hematoxylin stain. They stain purple. And with immunohistochemistry, these will stain with SMA or Desmond. And so these cells are myofibroblast. And the inclusions are intermediate actin filaments that are present within the cytoplasm, very characteristic of an infantile digital fibroma. And these lesions tend to occur very early in life, generally within the first year of life on the digits. They're usually solitary, and the recurrence rate is extremely high. They'll recur in up to about 2/3 of cases after removal. And some of them will spontaneously remit, but it's a tumor with an extremely high recurrence rate. So again, infantile digital fibroma. Well, I hope the slides here were helpful for you. I hope it gave you a chance to kind of practice your skills. For those of you who are just starting out, hopefully, if you can put it in the right box, tumor, neoplasm, deposit, whatever, that's great. And again, if anybody has any questions, please feel free to reach out to me. And likewise, we're always open to any suggestions you have for any topics you'd like us to cover. Hope everybody has a good evening, and we'll see you soon. Thank you.